Good evening, everyone. A warm welcome to the BMC Oncology webinar hosted by Balco Medical Center and supported by AstraZeneca and Intas. The theme for today's webinar is HER2-positive breast cancer, and it is organized by the Breast DMG at Balco Medical Center, consisting Dr. Mo Roy, Dr. Nupur Priya, Dr. Gaurav Gupta, Dr. Sandeep Ojha, Dr. Bhavna Sirohi, Dr. Fen Saj, Dr. Deepak Dapkara, Dr. Shishir Agarwal, and Dr. Jai Rai. Our esteemed chairpersons for today's webinar are Dr. Shona Nag, Senior Medical Oncologist and the Director of Oncology at Sahyadri Group of Hospitals, Pune, India, and Dr. Suman Mittal, Managing Director and Senior Medical Oncologist at Mittal Hospitals, Raipur, India. A warm welcome to you, ma'am. Moving on to our scientific agenda for today. First up, we have Dr. Sandeep Ojha, Senior Consultant Histopathologist at Balco Medical Center. Dr. Ojha will be speaking on the topic defining HER2-low. Over to you, sir.
So, good evening, everyone. So, today my topic is HER2-low breast cancer and how to define it. As we all know, breast cancer is most commonly diagnosed cancer in women worldwide. It is a heterogeneous disease with multiple oncogenic drivers like hormone receptors and HER2-new receptor. And treatment decisions are commonly based on conventional techniques like histopathology, immunohistochemistry, and immunohistochemistry for ER/PR HER2 and in situ hybridization. And based on this investigation, various subtypes of breast cancer are defined like luminal A, luminal B, HER2 positive, and triple negative. So we will focus today on HER2 positive tumors only. So what is HER2? It is a transmembrane growth factor receptor, and it is a type of proto-oncogen. So its amplification will lead to breast cancer. Approximately 15 to 20% of all breast cancers are HER2 enriched. So the primary purpose of evaluating HER2 status is to determine patient's eligibility for anti-HER2 therapy, that is Trastuzumab, Pertuzumab, etc. And it carries a worse prognosis compared to luminal tumor. So next point is how to evaluate whether the HER2 gene is amplified or not. So it is done using immunohistochemistry, where we see the protein expression over the cell membrane, and in situ hybridization technique, where we see actually the gene amplified within the cell. So both this technique, gene amplification and protein expression, correlates well with each other and in about 95% of the cases. So both the techniques are good. Now coming to reporting of HER2 by immunohistochemistry. So it is very important, as only positive or negative should not be given as a report. It should be scored. And we use here ASCO-CAP guidelines for reporting HER2, and it divide breast cancer into 4 subtypes. So this here you can see this brown color, and it is complete intense staining in more than 10% of the cell. So this is score 3 plus, that is positive. So this score 3 plus is considered as positive. Here you can see there is no brown coloration. Here you can see there is faint staining and incomplete staining less than 10% of the tumor cells. So this both categories comes under score 0. Here you can see somewhat brown color in more than 10% of the cells. So if incomplete faint staining in more than 10% of the cells, we call it as score 1 plus. And in score 2 plus, there is somewhat intenser staining in this category. So weak to moderate complete staining in more than 10% of the cells, we call it as score 2 plus. In this category of tumors, we have to confirm with in situ hybridization by using either single probe or dual probe. In single probe, we use HER2 probe to see whether the gene is amplified or not. If average HER2 copy number is more than 6 signals per cells, each cell is having more than 6 signals of HER2, then it is ISH positive. If less than 4, it is ISH negative, in situ hybridization negative. And if copy number is between 4 to 6, we have to do additional workup like concurrent IHC or perform dual probe in situ hybridization for final result. In dual probe hybridization, we use HER2 probe along with CEP17 probe, and we calculate the ratio. And if HER2 CEP17 ratio is more than 2, with average HER2 copy number is more than 4, it is ISH positive. And if HER2 CEP17 ratio is less than 2 and HER2 copy number signal is less than 4, it is ISH negative. So basically, this scoring system was initially made to predict the response in only in HER2 positive breast cancer, which may be in which HER2 therapy, anti-HER2 therapy can help. However, recent developments in antibody drug conjugates such as Trastuzumab-Deruxetecan have also led to notable survival benefits in patients with low HER2 expression. So as we have seen here, this is negative, this is positive. Here somewhat there is a HER2 expression which is score 1 plus, and here somewhat more intensity is score 2 plus. And score 2 plus ish positive is considered as HER2 positive, and ish negative with score 2 plus is considered as score 2 plus only. It is negative, but now it is terminology HER2 low is there, where take this category score 1 plus and score 2 plus ish negative as HER2 low tumors, and this is the definition of HER2 low, that is IHC score 1 plus and 2 plus ish negative. So why this is important? Because the Destiny Breast 4 trial has shown significant improvement in survival in these patients treated with Trastuzumab-Deruxetecan, but still CAP guidelines has not used this term as HER2 low in reporting, and they just added a footnote that patients with breast cancer that are HER2 IHC 1 plus or 2 plus with ISH negative may be eligible for a treatment that targets HER2 low cancer. So why this is very important? Because this HER2 low category can also be seen with hormone receptor positive as well as triple negative breast cancer, and all these cancers comprises approximately 55 to 60% of all tumors, and this much cases may get benefit from HER2 low cancer therapies. So this is very important. And to summarize, definition of HER2 low: score 0 is negative, 3 plus is positive, 2 plus ish positive is considered positive, and the definition by which we say that this is a HER2 low tumor is score 1 plus and score 2 plus ish negative, and that's how we define HER2 low tumors. Thank you.
Thank you so much, sir. That was a very insightful presentation. Now, join me in welcoming our next speaker for the session, Dr. Siddharth Turkar, Director of Radiant Healthcare and Research and Senior Medical Oncologist at Balco Medical Center. Dr. Turkar will be sharing his expertise on role of TXD in HER2 expressing tumors. Over to you, sir.
So my topic is role of Trastuzumab-Deruxetecan in HER2 expressing tumors. So we will be discussing the management of HER2 positive in metastatic breast cancer, the role of Trastuzumab-Deruxetecan in that, and HER2 low and its clinical implication. So TDXD is an antibody drug conjugate composed of three components. One is trastuzumab-like anti-HER2 IgG1 monoclonal antibody. It is linked with a payload, that is a topoisomerase 1 inhibitor, and a cleavable linker is there. So you can see in the diagram. It has high potency of payload, the high drug to antibody ratio, that is 8, payload with short systemic half-life, and stable linker. Payload is also there, and it can cause bystander anti-tumor effect. So this is the mechanism of action of Trastuzumab-Deruxetecan. In this diagram, you can see TDXD binds to the HER2, and then this is being internalized. Then linker is being cleaved and payload is released. The released payload goes to the nucleus and causes tumor cell death. And because of the membrane permeability, this payload can also go to the neighboring tumor cell, causing the bystander effect. So TDXD has demonstrated response to therapy in 60.9% pre-treated patient population with HER2 positive metastatic breast cancer. We will be discussing the evidence in Destiny Breast 03 trial, an open label phase 3 study. So they enrolled patients of unresectable or metastatic HER2 positive breast cancer that has been previously treated with trastuzumab and Taxane, and they could have clinically stable or treated brain metastasis. Generally, patients were enrolled after 2 weeks of whole brain RT. These patients were randomized in 1:1 manner between TDXD and TDM1. The primary endpoint of the study was progression-free survival. The key secondary endpoint was overall survival. Then there were secondary endpoints like overall response rate and duration of response in PFS also. The patients were stratified, pre-stratified based on hormone receptor status, prior treatment with pertuzumab, and history of visceral disease. Now you can see the result. So coming to the baseline characteristic, 50% of the patients were hormone receptor positive, 15% were having baseline brain metastasis, 70% had visceral disease, 61% has prior pertuzumab, and median 2 lines of prior therapy was given. So you can see the progression-free survival, the separation of the graph. It has increased almost 4 times as compared to TDM1, 6.8 versus 28.8 months. And when you see the overall survival, although it was not reached in both the arms, but if you will see the 24 months, 77.4% were alive with TDXD arm, and with TDM1 only 69.9% of the patients were alive. The anti-cancer treatment post-trial was received by 35% of the patient in the TDXD arm as compared to just 17.3% in the TDM arm. Coming to the side effect profile, the interstitial lung disease was seen in around 15.2% of the patient. None of them were grade 4 or grade 5. The most common toxicity was nausea and vomiting, seen in around 77% of the patient, and grade 3 neutropenia was seen in 16% of the patient. Now, the key subgroup of interest. So based on the 8 specific pooled analysis between the Destiny Breast 1, 2, 3 trials, they have seen that those patients less than 65 and more than 65, so there was not much difference in the median progression-free survival. It was almost similar between the group. When coming to the toxicity seen in this patient, so rate of educated ILD were higher in patients more than 65 years of age across the trial. You can see in the table, and most drug related ILD or pneumonitis were low grade. The other toxicities apart from ILD were also higher in those who were more than 65 years of age. Now coming to the CNS progression-free survival, as you can see, those who have treated or stable brain metastasis have benefited more from TDXT as compared to the comparator arm, as well as those patients who have untreated or active brain metastasis, they have more significantly benefited from TDXT as compared to the comparator arm, to 18.5 months versus 4 months in the progression-free survival. So those who have untreated active brain metastasis have benefited more from TDXT. Now, this you can see in the waterfall plot. Those who have received TDXD as maximum patients have partial response, and most of the patients have responded to the treatment as compared to the comparator arm, where lesser number of patients have responded to the treatment. So, shrinkage of brain metastasis was much higher in TDXD arm. In Tuxedo 1 study also, 73.3% of the patient had intracranial response. You can see in the waterfall plot, and progression-free survival seen was around 14 months. In retrospective ROSET BM study also, they have seen similar kind of results. Now redefining HER2 as a therapeutic marker, HER2 low and its clinical implications. So low level of HER2 expression are defined as HER2 IHC score 1 plus or 2 plus, as already told by Dr. Sandeep Ojha sir. And as you can see in this pie chart, you can see those patients who have HER2 positive, hormone receptor positive disease has more percentage of this HER2 low population as compared to those who have triple negative breast cancer disease. So those who are hormone receptor positive can harbor more patients who have HER2 low patients. So what is the challenges for interpreting HER2 low? There is no definition of HER2 low properly right now. There is lack of awareness of HER2 low. The tumor quality that is being biopsied is also not proper in most of the centers. There is heterogeneity of the tumor, and there is subjective IHC analysis, and sometimes there is limitation of the tissue itself. So TDXD efficacy in low HER2 low breast cancer is seen to be better. So you can see those who have IHC2 and IHC1 also have responded to the treatment. As you can see in the waterfall plot, those who have red lines have also responded to the treatment. Now in Destiny Breast 4 open label phase 3 study, they have seen those who have HER2 low unresectable or metastatic treated with 1 or 2 prior lines of treatment, and also those who have hormone receptor positive disease randomized in 2:1 between TDXD or treatment of physician choice. Again, the primary endpoint was PFS and the key secondary endpoint was overall survival. You can see the PFS in hormone receptor positive was better with TDXD as compared to uh, 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 treatment of physician choice, and in all patient also it has fared well, 9.9 months versus 5.1 months. The updated progression free survival data has is similar, 9.6 versus 4.2 months, and in all patient 8.8 versus 4.2 months. The overall survival was also better in the TDXD arm in both hormone receptor positive as well as all patients. The results from Destiny Breast 4 trial, efficacy in hormone negative, you can see the results were slightly less, but it has still better than the treatment of physician choice, 8.5 versus 20.9 months, 18.2 versus 8.3 months. The updated adverse event of special interest, uh, you can you can see that most of the patients have grade 1 or grade 2 toxicity. Grade 3 toxicity was very less seen, and any grade toxicity was also not that high. The ejection fraction failure up to grade 2 was just in 4%. Grade 3 was grade 3, grade 4, grade 5 was very minimal in these patients. Now, efficacy activity of TDX due to HER2 levels from HER2 negative Destiny 4 trial. So there was no difference in those who have IHC 1 positive versus IHC 2 positive. You can see most of the patients from both have responded in a similar manner, similar overall response rate and progression-free survival. Now, HER2 low expression is a dynamic expression and it may change from early to late stage of the disease. So, many of the patients who have HER2 0 can become HER2 low, and many of the patients who were HER2 low can become HER2 0. And depending upon that, their response can sometimes change. So, then the trastuzumab-deruxetecan in earlier line hormone receptor positive in ultra low category Destiny Breast 06 trial. In these, they have seen advanced metastatic after progression of 2 prior lines of endocrine therapy. Those who were hormone receptor positive or IHC was 0, 1 or 2 positive. These patients were randomized 1:1 between TDXD or investigator choice chemotherapy. Primary endpoint was again PFS and key secondary endpoint was OS, PFS and OS. So this they are finding, and in Daisy trial, what they have seen, depending upon what kind of expression is there, those who have HER2 overexpression has better responses as compared to those who have HER2 low, and those who have HER2 non-expression, the responses were relatively lesser as compared to HER2 low. You can see from the waterfall plot, and accordingly, the progression-free survival is in the similar manner, most in those who have HER2 positive disease. Now, coming to the toxicity, interstitial lung disease management, what was the trial protocol for that? So, for monitoring, what they have done every 12 weeks, they have done a high resolution chest CT scan, and at baseline, they have taken a clinical history and physical examination. HRCT was done, and baseline saturation was also measured in this patient, and pulmonary consult for patient with significant lung comorbidities was made. On TDXD treatment, HRCT every 12 weeks was done, or every 6 to 9 weeks with baseline respiratory symptoms. Whoever has a baseline respiratory symptoms, 6 to 9 weeks they have done. If ILD is suspected, HRCT was done in all the patients. So once these patients were suspected to have ILD, if it is grade 1, that is asymptomatic, dose was delayed. In those who were having grade 2, it was permanently discontinued. For treatment for grade 1, they have given started immediately on corticosteroid 0.5 mg per kg, or for grade 2 or 1 mg per kg prednisolone was started. The dose reduction that was being advised, if it resolved within 28 days from the date of onset, and resume therapy was done only in grade 1 when it has become to grade 0. So dose reduction 4.4 mg per kg dose to 3.2 mg per kg dose. After that, if further reduction is required, it was permanently stopped. So in summary, HER2 is a dynamic marker which can demonstrate intra and intratumoral heterogeneity and may also change from early stage to late stage disease. Proportion of HER2 low is higher in hormone receptor positive breast cancer compared to TNBC. Destiny Breast 04 significantly showed better OS and PFS in patients with HER2 low metastatic breast cancer who were treated with one or more lines of chemotherapy, with similar magnitude of benefit across all subgroups, including HER2 IHC 1 plus versus 2 plus and prior CDK4 inhibitors. Destiny Breast is evaluating TDXT in earlier line and in a broader patient population, including HER2 ultra low, that is uh, uh, more than 0 but less than 1 plus in patients. And based on the data from Destiny Plus 04 data, TDXT has been approved in 50 plus countries and it is recommended for HER2 low metastatic breast cancer by NCCN and ESMO guidelines. Thank you.
Thank you so much, Dr. Turkar. That was a very insightful presentation. Before we move on to our next speaker, requesting our chairpersons, Dr. Shona ma'am and Dr. Suman ma'am, if they have any questions. Additionally, our faculty and our participants can also type in their questions in the chat box.
So I think that was a great overview, first of all, of redefining a new subtype called HER2 low. And I think we've covered the clinical data quite well and touched upon the toxicity. So I think we can take the questions right at the end and maybe bring all the doubts up during the panel discussion.
For our next topic, please join me in extending a warm welcome to Dr. Marina Parton, medical oncologist in breast cancer at the Royal Marsden, United Kingdom. Dr. Parton will be sharing her practical experience in using TXT. Over to you, ma'am.
Right, so I'm Marina Parton. I'm a breast medical oncologist at the Royal Marsden, and I also have a picture of the Fulham Road building there on the left-hand side, and I also go to a satellite unit at Kingston a couple of days a week. So I'm split between a very big cancer centre and a small cancer centre satellite unit. We've started to use DTXT in the last 2 to 3 years, and most recently in the private sector, started using it in HER2 low. These are my disclosures. Some of these slides may be familiar. So this is the background to DDXT monoclonal antibody with a cleavable linker and a powerful payload with Deruxetecan at a ratio of 8:1. And moving on from HER2 positive breast cancer, DB04 has really expanded the use of DDXT outside the HER2 positive population, and we're finding that increasingly as we get more comfortable with DDXT, we're using it more and more earlier and earlier in the HER2 low patients because the efficacy, it appears to be very good, particularly in women who have quite a high disease burden. Now, we've already touched on some of the side effects associated with DDXT. The nausea is surprisingly common. It's a very different drug from Kadcyla. It's very different, very different. There is much more in the way of fatigue. Even very young patients find the treatment initially, quite hard going. And of course, the ILD is something that you have to watch out for right from the beginning. So I'll just reference you to a Sandra Swain paper published in Cancer Treatment Reviews, in which they really focus on ILD in DDXT. And it's in the early studies, this was quite a concern, but as the studies have progressed, as the Destiny studies have progressed, the protocols regarding monitoring, early pickup and management has completely changed how ILD is managed, and many more patients are able to continue with therapy without this complication. Now, in these set of pictures of CT scans, you can see that the ILD can be quite florid and can be interpreted as infection. So you're relying on your radiologist or yourselves to interpret the scans very early on so that patients can be treated with steroids, and these changes can resolve completely. So in DB04, the number of patients who experienced ILD or had features of ILD was in the region of 45%, but nearly all of those patients were either grade 1 or grade 2. Grade 1 being completely asymptomatic and grade 2 minimally symptomatic. Unfortunately, there were patients that died of the ILD within that original study. So it looks as though when you look at the development of ILD with DDXT, it appears to come on at about the 5 to 6 month point. So most patients would have started treatment, had their interval scan at about 3 months, so hopefully would be responding or stable, and then they may encounter the ILD. When people carry on with DDXT beyond 12 months, there appears to be no further incidence of ILD. So that's very reassuring. If you have a long-term responder doing well on the treatment, they can continue without that concern regarding the ILD, and you can actually de-escalate your monitoring. So in the original pooled analysis of the Destiny studies, they looked at features that might predispose patients to developing ILD. So they found older patients, Japanese patients, and non-Japanese patients. Of course, this drug was originally developed by Daiichi in Japan, so they saw ILD much more than in other ethnicities. Higher doses, the dose that we use, have the lowest level of ILD, but the original phase 1 studies, you were using doses of 6 milligrams and 7 milligrams per kilogram, so the incidence of ILD is much higher. People who have low oxygen saturations at baseline, impaired renal function, and other significant low lung comorbidities appear to have a higher risk of ILD. Interestingly, lung metastases and lymphangitis does not appear to predispose to ILD. And of course, heavily pre-treated patients. So if they've had metastatic disease for a number of years and several lines of therapy, they again appear to be more vulnerable to developing ILD. Of course, in all of these cases, in the original pooled analysis, most of the ILD that was picked up was grade 1 or 2. So I'm going to run through a couple of clinical cases, one of whom was quite early on when we first started using DDXT. And since then, we've refined how we've used it. And I just want to briefly talk about some of the things that we've done to make this drug as safe as possible for our patients. Certainly now we use DDXT routinely in the clinic, not just in the big centres, but in the peripheral satellite units. And with the monitoring that we've instituted, we consider it fairly safe. So the first case history is a 27-year-old, no pathogenic germline mutation, who was diagnosed in 2019 with a grade 3 ductal cancer, ER positive, HER2 negative. She was treated with surgery, adjuvant chemotherapy, FECT, and hormone therapy with Zoladex and tamoxifen. Unfortunately, 3 years later, she developed symptoms which were suggestive of recurrent disease. She was found to have multi-site relapse in the breast, axilla, bone, and liver. Tumor biopsy confirmed recurrent ER positive, HER2 negative breast cancer. She was started with first-line hormone therapy, ovarian function suppression, fulvestrant and palbociclib, which was our drug of choice at that time, and denosumab. Unfortunately, within 4 months, she had progressed and she was switched to first-line weekly Taxol. That resulted in a mixed picture with stable bone, but areas of progression in the liver. She had a further biopsy of the liver, and this confirmed ER poor, PGR0, and HER2 2+ D-dish negative disease, and she was also found to have a pathogenic PIK3CA mutation. And that was actually picked up on the ctDNA, which was done concurrently within a study. She had a trial of alpelisib and fulvestrant, but unfortunately had quite severe skin toxicity, and we dose reduced. She had low-dose steroids continuously, but was not able to continue with therapy. Due to further progression, she was switched to oral capecitabine, and despite not having a DPD heterogeneity, she still developed quite marked side effects with hepatitis and jaundice with the capecitabine. And so she was moved on to gemcitabine and carboplatin. So within a relatively short interval, so she'd only had relapsed disease for a year, she'd already progressed through at least 3 lines of therapy, and had 2 lines that she wasn't able to tolerate with the alpelisib and the capecitabine. The platinum therapy, again, was not very successful, and Enhertu at that time, DDXT, was available in the UK and had just had a license for HER2 low. So she chose to self-fund this. She was an NHS patient, so she paid for the drug herself. And fortunately, within a couple of cycles, we could see a significant improvement in her liver function. However, only a month or 2, only 6 weeks actually, after starting treatment, she developed a fever and a cough. She called our hotline. It's a service that runs 24 hours, which patients ring if they're unwell. Due to the urgency of her symptoms, she was told to go to the local emergency department. There she was found to be short of breath. She had chest pains, quite marked reduced saturations for a girl of her age, raised CRP. She had a CTPA, no PE was found, and it was reported that she had pneumonia. The scans were sent over to us at the Marsden, and actually we read the scans with our own radiologists and diagnosed ILD. Now, this is where you are really dependent on your radiologist, because if patients are being admitted to other hospitals, that's often the case here in the UK, they go to their local emergency department that are at risk of developing ILD and being treated for infection rather than steroids. So at this point, she had symptomatic grade 3 pneumonitis. She was started on prednisolone. DDXT had already been stopped, and fortunately, we were able to catch it in time, and she had complete resolution of her CT changes, and she was able to continue treatment with Ribulin. However, as has been the pattern with this lady, she only had 2 more further lines and then unfortunately died. But the ILD was manageable. It was picked up in adequate time to be treated with steroids. So this is the second case. So again, similarly, a young girl who presented originally in 2010, no pathogenic germline mutation, and she had a T3 node positive, grade 2, ER positive, HER2 negative breast cancer. She had FET-T chemotherapy, so she had surgery, FET-T chemotherapy, tamoxifen, and radiotherapy. 8 years later, she developed lung and bone metastases. She had a biopsy, and this confirmed recurrent ER positive, HER2 negative breast cancer. And she was treated with first-line ovarian function suppression, letrozole, palbociclib, which was our drug of choice at the time, and denosumab. A couple of years later, so she had evidence of estrogen sensitivity, but however, she progressed in the liver and bone. We repeated the biopsy. This was actually part of a clinical trial. She was found to be ER poor, still HER2 negative, and she was offered oral capecitabine. Due to further progression, particularly in the liver, a liver biopsy was arranged, and she was identified to have a HER2 positive breast cancer. And this is, as you will appreciate, a little bit unusual, but actually fortuitous, because it allowed us to expand the treatments that we could offer at that time. So we used the Cleopatra schedule with weekly Taxol, Herceptin, and Pertuzumab as first line. As the sequencing for our patients at that time was to use Kadcyla second line, and hence on progression, after a relatively short interval, she entered into clinical trial HER2CLIMB. The randomization was to either Kadcyla, the standard of care, or to tucatinib, capecitabine, trastuzumab. She was randomized to Kadcyla. However, within weeks, there was evidence of progression, and so she was able to move on to TDXT, which was then available as third-line therapy. It's now moved to second-line in the UK. Within that time, she had also developed symptomatic new brain metastases, and she was not suitable for radiosurgery, so was treated with whole brain radiotherapy and high-dose steroids, and was able to continue with the Enhertu. So if we look at how long she'd been on therapy, sorry, I think my timeline's incorrect here, but she had actually been on Enhertu for about 6 months when she developed a cough. She was treated with her GP with antibiotics. She didn't contact us, and there's a bit of learning here that patients should be looking to us first before going to their general practitioners in primary care. Later on, a few weeks later, she became more unwell with shortness of breath and exertion. She did contact us, and she was advised to go to the local emergency department straight away. Oxygen saturations were 92% on air when she arrived. Now, as we had been informed at that time, we contacted the emergency department, and she was able to start steroids straight away. However, she continued to deteriorate, and then within weeks was on 50% oxygen. Because of her young age, they elected to ventilate this lady, although I have to say, in our own institution, I think we would have held back from that. Despite the ventilation, her oxygen requirements increased, and as you'd expect, her lungs became increasingly stiff. And with consultation of the family and ourselves, we withdrew treatment. And unfortunately, this lady did die of her ILD at that point. She also had a background of progressive breast cancer. She'd been off treatment for a while, but until that point, there was evidence of response to Enhertu. So I think with those two case histories, one of the things that really strikes us now is that the pool of patients who are now receiving DDXT is much larger than before. Previously, we had a fairly youngish HER2 positive population, small numbers compared to the large number of hormone positive breast cancer patients that we treated in the metastatic setting. And now we're seeing far larger numbers of patients being treated with DDXT. Often they're more heavily pretreated, that may have had metastatic disease for a number of years, because we go through our endocrine lines of therapy and one line of chemotherapy before offering DDXT. Patients are more likely to be older, as you'd expect for a estrogen positive breast cancer population, and of course older patients being more comorbidities. We've already touched on some of the algorithms of identifying these patients, actively looking for pneumonitis, interrupting the drug early, working the patients up quite quickly, not just with high resolution CT scans, but also involving respiratory teams. Also, not forgetting that some of these patients, because they've been on treatment for a long time, may also have infection, atypical infections. So not to forget our basics in managing pneumonia or pneumonitis for other reasons. And according to the SBC in our own practice, if incidental pneumonitis is found and treatment interrupted, then you'll get a resolution and you may be able to return to the drug again. But once grade 2 or grade 3 has set in, it's not possible to re-challenge with the drug again. So just to remind you that grade 2, grade 3 and beyond, re-challenge with Enhertu is not recommended. So the steps that we took with our initial experience with DDXT was a question of really making sure that everyone in the patient pathway is aware, both the nurses, the chemo nurses, the CNSs, and all of our colleagues, including juniors. We had quite set protocols put into place. It's in our consent forms, a risk of pneumonitis, and the patients now have alert cards as well. We have a programme of checking oxygen saturations, both at rest or exertion before every cycle of therapy. And at the Marsden, we do 6 weekly CT high-resolution scans for the first year, although that's not common in other sites because that actually has huge demands of the radiology department. So the PET CTs that we do normally at 3 to 4 months for monitoring our patients don't have adequate resolution to pick up pneumonitis. There'll be 5mm slices, and you really need less than 2mm slices to look through the chest. So patients being monitored with PET CTs also have additional high-resolution CT tests. And as I said, we do it 6 weekly at the Marsden. At other sites in the UK, they're doing between 8 to 12 weeks, as discussed in the previous presentation. So as I've said, huge demands on our radiology, and it's not actually doing the scans, it's the reading of the scans, which is our issue. We have capacity on the CT scanners, but we just don't have enough radiologists to read them for us. So we have information cards that we give to the patients to remind them about the risk of ILD and shortness of breath. It's in our consent forms. It's a separate feature that we always draw to the patient's attention when they start treatment. And it's actually a hard block on our prescriptions, on our electronic prescriptions, so that when patients have treatment, the pharmacist and the nurse giving treatment have to check for when the recent CT scan's been done. And this is just a quick slide about using, about re-challenging patients who have had previous ILD. But of course, pneumonitis is not new to us at all. We manage patients on immunotherapy, everolimus, abemaciclib. We've seen it before. It's just remembering for these patients that we screen them adequately before treatment. And what I'm going to do is just going to jump my last 2 slides a bit, Padna, to give enough time for discussion. So our standard for nausea is aprepitant dancetrol steroids, a bit like anthracyclines. It's quite a metagenic, the schedule, and a lot of my patients continue with domperidone, metoclopramide or cyclizine all the way through for the 3 weeks. It's quite a problem for some patients. And rashes and fatigue are the 2 things that you really don't see in Kadcyla at all. That's quite prominent in DDXT. Thank you very much.
Thank you so much, Dr. Marina Parton. That was a very insightful presentation.
So can we just have a few questions? I know, Marina, you have to catch a train.
Yes, I've got a little while. I'm sorry I overran just then.
No, it's just, the 6 weekly CT scans, that's, I mean, you yourself said it's quite a bit. So what percent, are you seeing more pneumonitis than what's reported?
No, so we're not seeing a lot actually. So we started off, we had that death actually of that lady who's quite early on in our experience with DDXT. And so we went back to DB04 and looked at the protocol. And the protocol actually stated 6 weekly high-res CT scans, and that's what we instituted. And that's kind of stuck since then. Now we are auditing it, and we are going to de-escalate it. Now, because we've got good radiology capacity at the Marsden, we're able to do it. But nationally, no one's doing 6 weekly CT scans, from I understand. Some are doing 8 weekly, but a lot more are doing 12 weekly. And that was actually in the previous presentation, that the recommendation is 12 weekly unless people have symptoms. But sometimes it's not clear, I have to say. If you can pick up ILD very early on, incidentally, you can just pause treatment and then go back again. By the time they have symptoms, they have to come off and they can never go back on.
Yeah. And in the NHS, they've not approved the HER2 low TDXT. So the reason is that the benefit is small, or
I
what?
think it's a combination of the volume of patients that are going to be treated and the cost as well as the benefit. So the way it's calculated, that what I mean, you have AstraZeneca involved in this meeting, but I think these kind of drugs that really have quite significant impact on your practice. I don't give Eribulin third line anymore, second line. I'm giving DDXT now. It's just so effective. And so the volume of patients that we'll be treating, I think, in the next year or so, if it becomes widely available, will be huge. And I think NICE are just holding back a little. They are trying to negotiate with AstraZeneca regarding cost, because it's going to have a huge impact on the NHS.
Yes, absolutely. Dr. Siddharth?
Yes, ma'am. Actually, I want to ask if you are using it before TDM1. So those patients who have progressed on TDXT, do they respond to TDM1, or like can it be a valid option after TDXT?
Yeah, so I've seen patients respond. It's a little bit uncertain. I think there is some data now showing, looking at that in greater detail. But since DDXT moved to second line after Trastuzumab, everyone's jumping Kadcyla, but there's some people who just do not get on with DDXT. There's no doubt. And the nausea is, rather than ILD, it's a nausea that's a problem for a lot of my patients. And so as soon as we get to Kadcyla, you can still get very good responses. I actually loved Kadcyla previously. I think it's so tolerable. I've got so many patients who are on it 2 or 3 years with good disease control, and they have a really normal life. DDXT is different. It's much more tiring. So it does compromise their quality of life a little bit more, but of course it's highly effective. So you have to make the decision. I normally say to patients with very small volume disease, I offer them the chance to have Kadcyla first, although our pathway is DDXT second line, just for quality of life, with a view to moving on to DDXT if they need. But with high volume disease, then DDXT is always another choice.
Okay.
One more question regarding TDM1, regarding a toxicity that I have seen, but I have not, because of TDM1, one of my patient has platelet dysfunction and she is having intermittent bleeding. So it has been reported in few case reports that it can cause platelet dysfunction. So is there any treatment for that, and how common is that in your practice?
Yeah, so I see it the most in adjuvant TDM1. So after, as per Catherine's study, we offer 14 cycles of TDM1. I've had now 3 patients, myself personally, come off because of thrombocytopenia, unmanageable thrombocytopenia. And apart from dose reductions, and once you've hit your band level or level 3 dose reduction, you've got nowhere else to go. So they switch back to Phesgo. It's not something that I've seen with TDXD, though. I think this is a TDM1 effect.
So, regarding some patients can have normal platelet count and still have recurrent epistaxis kind of a thing, because it is also being reported without thrombocytopenia, they have platelet dysfunction, and like how long does it stay? I don't. There is no proper guidance on that.
I've only had one lady where this has happened, and she developed. So I did have one lady who had catastrophic epistaxis actually and needed transfusion, and she had a normal platelet count, but she was found to have pseudocirrhosis with the TDM1, and that was only apparent about a year later. And I don't know if that was associated, but I don't have any other clinical experience of it. So pseudocirrhosis with long-standing TDM1 is a recognised effect, and it is on the SPC. But as we have more and more patients, I think we'll have the odd patient between us that will have this. But pseudocirrhosis was a surprising finding, and she actually presented with splenomegaly and thrombocytopenia and a very cirrhotic liver by the time we diagnosed it. And apart from Kadcyla, we can't see, because this was all given the adjuvant setting, what else it could be. And she had epistaxis all the way through her treatment. I don't know the mechanism myself, sorry.
Yeah.
I have a question.
Yeah, Shona, go ahead.
Yeah, so thanks, Dr. Parton. That was very, very nicely explained. My question is that we have in the metastatic setting so many patients on Fesco or Draspert, and they have a brilliant quality of life. So, as I understand, the drugs move earlier and earlier, the better they are. So, in the event that we've got TDXT in first line setting, which I'm sure the trials are ongoing, uh, how would it compare as far as quality of life? Because you've talked of fatigue, you've talked about a lot of chemo-like side effects, this constant worry about ILD. So, Fesco's been a breeze so far. So, how would it compare?
It's such a dramatic difference between the two. It's difficult, and I think this is a bit like the CDK4/6 inhibitors. I don't know in your practice if it's changed as it has in our practice, that palbociclib, our most favourite of drugs in the first line setting, has now been completely replaced by ribociclib and abemaciclib. No one gives, well, palbociclib is hardly given first line unless patients have significant comorbidities. And that's a real shame, I feel, for some women who are going to struggle with the ribociclib side effects, particularly if they get deranged LFTs. And so I've now got into the habit with the CDK4/6 inhibitors is actually going through the data with patients. It's quite time consuming, but I explain to them why I'm not offering a drug that might prolong QT or a drug that might not give them diarrhea, why I'm opting for palbociclib, because I think the data is good enough to have this drug for their cancer. And I think that those are the kind of discussions we're going to end up having with HER2 positive disease, because there's no doubt that some women with due to volume of disease, comorbidities, this is just not going to be the right drug for them for long term. And we're going to have to almost counsel them that this is why I'm recommending a drug that doesn't have the best efficacy.
Right.
And I think that's the way we're going to move forward. I think medical oncology is just going to get more and more complicated because these kind of discussions and decision sharing is going to be what we're going to have to do.
One more question from my side, if it is being allowed.
Please go ahead.
I have a patient who has initially HER2 positive disease, and she has been treated extensively with Fesgo and Kadcyla. And now repeat biopsy is showing triple negative breast cancer. And they are well affording, and they are started on Trodelvy. So in this kind of patient, is TDXD can work? Because probably she has a heterogeneous disease, she has HER2 positive population and with triple negative population as well. So what is your experience in such kind of patient?
So was it HER2 0, HER2 1+?
So in the recent report, it is HER2 0.
HER2 0.
HER2 0.
So the natural instinct is that if that biopsy was from a progressive lesion, and the new lesions are your biggest problem, I'd probably go for Trastuzumab-Deruxetecan. I'd probably go, if they've already had one line, sounds as though they had a platinum, is that right?
And she has received extensively, and right now she's already on Sacituzumab. But what is the next line I can try? I can give.
I think after Sacituzumab.
TDXD I can think of. Probably.
Yeah, but I wouldn't give it in HER2 0. The data isn't mature enough to give it out of study. So I would still hesitate to give TDXT for a HER2 0 patients. But if you're confident that there'll be other HER2 positive disease, then why not? You can swing it either way. But I mean, the DAISY data is there, and that looks quite promising. But I don't have the confidence to treat someone HER2 0 if I think their disease is mostly triple negative. But this is unusual because the patient was previously HER2 positive. So you could, it wouldn't be wrong.
Yeah, yeah. Great. Any further questions? Great. Actually, Marina, in our molecular tumor board, there are two areas we've identified. One is like in every tumor board, we recommend TDXD for at least 1 or 2 patients, either gallbladder or colon for HER2 1+ or 2+. And the other area we identified to do collect real world evidence was ER positive and very high TMB, like, TMB of like 60, 70. So identify, and it was 90 in one patient who was presented 2 weeks ago. So we've got 4 patients like that. So we
And
thought.
what did you do with them?
So we've given them immunotherapy.
Yeah.
But with the
Single agent.
collect the data. Yeah, we need to collect the data to see what happens. So we'll follow them up in 3 months' time. But we've decided to collect the data. We have 2 patients from Turkey and 2 from India. So, and the other area is looking at TDXD in different tumor types, because the molecular MDT is not just breast, it's every cancer from all over India. Anybody can present a patient. So
That's fantastic.
yeah, so it's quite interesting. Great. Really enjoyed your talk, Marina. Thank you so much. Thank you. Thank you.
Have a great evening, everyone.
Thank you. Achal, you can take over.
Sure, ma'am. With that, we have come to the end of today's session. A heartfelt thank you to our chairpersons, Dr. Suman Mittal and Dr. Shona Nag, our speakers, panelists, organizers, sponsors, AstraZeneca and Intas, our event partner, Riverroot Events, and our audience for your participation. Let's continue our efforts in advancing the field of oncology. Thank you so much. Good night, everyone.
Good night. Thank you. Bye-bye.